Welcome everybody. Thanks for tuning in now and those that'll tune in later on the recording to the National Fellow Online Lecture Series. I'm your host. My name is Scott Young. I'm an emergency and sports medicine physician at the University of Washington School of Medicine in Seattle, Washington. And it is my distinct pleasure to introduce Dr. Chris Kwan. Dr. Kwan is an associate professor of orthopedics here at the UW. He grew up in the Seattle area and went to medical school here as well. But then he moved to Scottsdale for residency at the Banner Good Samaritan Mayo Clinic orthopedic surgery program, and then completed his fellowship at the University of Michigan. He is a former orthopedic residency program director here at UW and a current team physician for both the University of Washington Huskies and the Seattle Mariners. And excited to hear his talk today about the evaluation and management of traumatic sports injuries to the knee. Before we get going here, I just a couple things as we always cover. First of all, the goals of this talk are really to augment your home program's educational content and to give you access to expert speakers and AMSSM members in a wide variety of sports medicine topics. And of course, it's to assist everyone in CAQ exam preparation. As always, the rules, remember to mute your device's microphone and turn off your video. You can submit questions through the chat function, and we'll have a chance to cover that stuff at the end. We'd also love for you to complete an evaluation at the end of the talk. There's a couple ways to get to the evaluation. One is through amssm.org. Go through the education page, and you'll find it there. Or the fast way is just using this QR code, which you can take a photo of now and then scan it later to run the evaluation. But we really appreciate your feedback, and it helps guide us in the topics that we choose and the speakers that we get. And the last thing is, in terms of educational content, we also have a great library of sports ultrasound pathology that you can not only review and learn from, but you can also submit stuff, which can be published and you can put that on your CV. It's a great opportunity. Again, recommend taking a picture of that QR code so that you can access that stuff later. And finally, our next topic, well, congratulations to everybody. You made it through the academic year. The next talk will be in August, and the topic will be announced soon. But with all that, I'd like to turn it over to Dr. Kwan for today's presentation on knee trauma. Dr. Kwan, the floor is yours.
Okay. Thanks, Dr. Young, so much for that introduction. I'm really pleased to be able to share some insights on the evaluation and management of traumatic sports injuries to the knee. As you all know, I'm based at the University of Washington. It's located in beautiful Seattle. Our clinic is actually underneath the south stands of Husky Stadium. So that's where I practice. The overview for the talk today is to provide, a little bit of background about traumatic sports knee injuries and some of my evaluation and principles and management philosophies as an orthopedic surgeon, seeing knee sports trauma pretty commonly. Maybe use a handful of illustrative cases to dial in how these principles and philosophies tie together to make good decisions for the patients that we see. And then at the end, add a couple miscellaneous knee sports trauma pearls coming from the orthopedic perspective that might be helpful for everyone involved taking care of athletes at every level. And then hopefully a little bit of time for questions. I have no disclosures. The traumatic sports knee sports injuries, we know that they're ubiquitous, they're happening all the time. The knee, at least with data and in my experience, is the most commonly injured joint from playing sports. There's varying degrees of presenting symptoms, pain, swelling, and other things that patients report, varying degrees of resultant disability from those symptoms. And there's obviously a huge spectrum of return to sport issues, whether it's back on the field right away or even a year or more lost to recover from that particular knee sports injury. And then also kind of tying in that the acute traumatic knee sports injuries can become chronic or long-term injuries that affect things beyond sports. So when I initially started putting this talk together, I actually was going by diagnosis a few of the common um, injuries that actually I see and treat and do surgery on, and was just going to do my typical spiel about what fractures and what ligament and tendon and cartilage injuries there were. But to be honest, that is content that exists out there that you can find out on your own quite easily, better than what I could disseminate in a 45-minute lecture. We know that there's bony injuries that can happen from playing sports, whether they're articular injuries of the tibia plateau, distal femur, proximal fibula, or undersurface patella. We know that there could be extracapsular avulsion injuries, usually involving ligaments or soft tissues that are attached to those things that pull off the bone. We know that there's a variety of ligament injuries. I know there was a really good talk earlier this year that went through a lot of this stuff as it relates to sports trauma. And there's the tendon injuries around the knee, whether it's the patella tendon, quad tendon, the hamstring tendons, or some of the other tendons that actually, have attachment points in and around the knee. So we know that these all exist and that they can be injured playing sports. And lastly, we know that there's, cartilage injuries that can happen, whether it's the soft meniscus cartilage, articular cartilage injuries, and they can be damaged in varying ways, from playing sports. We know that sometimes cartilage and bone can get injured acutely with some of the knee injuries that we see. And then there's other things that aren't super common, whether they're vascular or nerve injuries. They're almost always in conjunction with the multiligamentous knee disruption or knee dislocation episode. And then some of the more chronic or non-acute conditions that are related to sports, and I book them in the bigger categories of wear and tear, overuse, and some of the really uncommon, zebra conditions that you got to look up when you see them. The most common knee sports trauma diagnosis, though, far and away, is the knee bruise. Just falling on your knee. You know what? You could call it contusion if you want to sound fancy. And the bruise or the contusion can be superficial or deep. And again, we're gonna move from this very common thing to some of the other things. We're not here to list all of those things, though. We're talking about evaluation and management. So I'm gonna talk about the rest of this about in those two realms, evaluating the knee sports trauma and then what to do to manage them back to uh, return to sport and back on the field. So these evaluation principles, I think, are going to be helpful in any setting, whether you are a team physician standing courtside or on the sideline. It will they actually also can be helpful in the setting of a urgent care if you staff an urgent care or an emergency department, seeing someone who comes in, from the fields just hours ago from an injury. These evaluation principles actually can be utilized in the office, whatever your setting is, and whether that evaluation of the sports knee injury happened a few days ago or even a few weeks ago, these evaluation principles still, hold firm and can be helpful. And remember, at any time, the knee injury just happened now in front of you. The knee injury happened yesterday, or it happened weeks or months ago. So again, those marry in with the setting that you might be practicing in when you see these injured athletes with their knee trauma from playing sports. But again, it applies. Just as to a clarification point, for this talk anyway, we're talking mostly about trauma, right? I was playing sports and having the time of my life. Something bad happened, and now my knee is not right. That is what we're talking about primarily, the acute traumatic sports injury, the soccer thing, the basketball thing, the football thing. An entirely different talk is knee symptoms or problems from sports that are not traumatic, that don't have a one-time mechanism or that you could classify more as a subacute or chronic or a sports associated injury, not a sports trauma injury. So, example, I've been playing a lot of pickleball lately and my knee hurts from that. Or every time I try to go hard with some activity, my knee swells. I feel a pop or a click whenever I do some sort of sporting activity. So that's for a later day, different topic. We're talking about the acute one-time trauma thing, just for clarity's sake. Okay. For me, evaluation of a knee trauma sports injury starts with an assessment of the acuity level. Um, and acuity level for me is like DEF CON level. So like the DEFCON 1 is like something actively bad is happening, and DEFCON 5 is just nothing. And so the acuity level to me is similar to that, in that the higher the acuity level, the more you have to do, the more serious the situation is, the more pressing the thing is, and the more you have to, be ready to act or be kind of on high alert. And so the things that we do as sports medicine physicians when people injure their knees playing sports is you can remove them from the game. You can offer immobilization or protection or braces and recommend time off and order studies, whether it's imaging or something else, and get other people involved. Those are things that we do in the process of evaluating a problem, and knowing that the higher the acuity, then the more of these things you have to do. So the acuity itself initially is determined by the loss of function of our athlete when they hurt their knee, and any red flags on history, exam, or imaging, if you're in that setting. So the assessment of function specifically mostly comes from the history. Some of it comes from the physical exam. And that assessment of function is basically answering the question of what can they do or not do with their knee after this acute traumatic sports knee injury. And sometimes they can do everything. And sometimes they can do some things, and sometimes they can do nothing. So we see that, right? We see people that have knee injuries from sports that are kind of functioning and still able to do their sport. And then we have some people who injure their knee playing sports who cannot even walk, cannot bend their knee, can't do anything. And we could immediately acknowledge that those two scenarios represent a different level um, of acuity, and thus a corresponding different level of action that we need to take. So, as of the second part of the evaluation, which is the assessment of the function, the loss of function, the other part of the acuity assessment is identifying red flags, red flags in the situation. And in my opinion, that's actually the most important thing that we do as physicians in general, and it's for sure the most important thing we do in a trauma situation, and then there's that corresponding thing when if it's a sports trauma. Now again, it's different from life-threatening trauma or trauma in the Harborview sense or general surgery sense, but the idea is the same. Identifying red flags is a really important part of what we do as physicians who evaluate traumatic injuries. Sometimes those red flags are just from the mechanism, like being a ground level fall, for example, activates something in the trauma world, or being in a high-speed car accident. Just that mechanism warrants a certain amount of action or a bundle of action. Just like in our world, loss of consciousness, just that historical factor mechanism of injury warrants a certain amount of action that otherwise would not be triggered if they did not have loss of consciousness. So we have similar things, at least in our world, with the knee injury mechanisms that have a similar effect. Sometimes the red flag is something that we see or touch on physical exam, or sometimes that red flag is an imaging finding, what that automatically triggers a level of action or a level of acuity that warrants a level of action because it is present, regardless of anything else that's going on. So some red flag examples from the history from a knee trauma, sports knee trauma standpoint would be falling down, twisting their knee badly, hyperextending it badly, the knee buckling, the athlete reporting that the knee feels unstable or that they couldn't walk because of their knee sports trauma, that they have lost motion in one direction or another, either flexion or extension, or that they feel like they can't activate their muscles, or that the knee feels weak with extension, flexion, or anything around that extremity. So those would be historical red flags. Well, anytime I hear this in part of the HPI, then again that those things have raised the acuity level, and we'll show examples of the opposite where maybe the acuity level is not that high because of that history. Physical exam, same thing. When you see a knee that's deformed, that's really swollen, that has loss of strength on exam or a loss of motion on exam, or has bad ligament laxity on special testing, we know that these are in and of themselves red flags that need to be accounted for, and that when a part of the evaluation raises the acuity level, raises the things that we need to do. There's some imaging red flags also, basically fractures and dislocations. We know that when we see these things that there's a hard stop with what we should be doing in terms of what we allow them to do, or the next steps that we have to take in terms of getting people involved or immobilization or bracing or whatever it is. Some other red flag examples are torn or disrupted tendons or ligaments. We're often seeing these with advanced imaging, so maybe not, obviously right on the field, but things that happen in the course of the flow of clinic evaluation or outpatient evaluation. But having these things sometimes in and of itself then cause a series of actions that need to take place because the acuity level has been raised simply by having this imaging finding. And again, same thing with certain types of meniscus damage, specifically the badly displaced bucket handle tear of the meniscus, as an example of that. When that exists, it often corresponds with history red flags and physical exam red flag findings as well. But again, when you see this, then it raising the acuity level in and of itself. All right. So that, like I said, that greater loss of function is often, if not always, tied very closely to the presence of more red flags on the history and the physical exam. So the inability to walk or the inability to put weight on the leg or the inability to straighten often comes with the associated physical exam abnormality or red flag. And then that subsequently warranting more evaluation or more action. And remember, the red flags on imaging, though, can be variable. History and physical exam tie together very, very nicely or often. Imaging red flags can be variable. Most fractures and dislocations are actively messing people up. But not all meniscus or cartilage tears mess people up, or not all meniscus tears cause a block of motion or a lot of swelling, and not all ligament sprains cause a bunch of pain or inability to move or bad laxity on physical exam. So these are things where we gotta put the clinical correlation together with the imaging findings. And that's like with anything, not just knee sports trauma. So evaluating a traumatic sports knee injury is again driven by the acuity assessment, and that assessment is complete when you have a firm diagnosis in hand or when you feel confident that nothing bad is happening. That's again exploring the red flags, identifying the red flags, and making sure that those have been attended to. So when that evaluation is complete, then you move on to management and treatment of your traumatic knee sports injury. So what do we need to do from a management standpoint once the evaluation is complete? Funny, it's actually assessing the acuity. However, and that acuity, like it is in the evaluation part, when done in the management part of the knee injury, the higher the acuity, the more you have to do. And these are some similar things that you have to do from a management standpoint when the acuity level is high. When you're evaluating a knee sports injury, however, that acuity is determined, like we just said, by loss of function and red flags on history exam or imaging. When you're managing that knee sports injury, the acuity level is more determined by the treatments that have been attempted and the patient unhappiness, frustration, or goals. So what do I mean by that? Treatments attempted is pretty clear. That's non-surgical or attempted things, giving it time, modifying activities, trying oral medicines, bracing, immobilization, topicals, therapies, injection. These are all things that everyone who is listening to this talk are very good at, providing treatment, counseling, and taking care of the injuries that you encounter. The second part of the what drives the acuity level, though. So again, everyone can understand that the more of these things you do and the persistence of the problem raises the acuity level. And then similarly, the patient frustration, that raises the acuity level, at least in my book. When the problem the resolution of the problem is taking too long, or the symptoms when they're present are too limiting, or they got to really just do a lot to make the symptoms be at bay or to start coming down. Or they might be impatient. They got things to do, places to be, that's not along the timeline that they want. They don't understand like why it's taking so long or why we're doing the treatments that we're doing. So there's a lot of things that go into patients being frustrated or patients just feeling like they've just had it with their knee or sports injury. And we could all appreciate that when people just have been fed up with the problem and when they've tried a lot for the problem, then the stakes have been raised, the acuity level has risen in the management phase of this injury, and more needs to be done. So whether that's escalating imaging, different testing, instead of just oral medicines, trying the injectables, instead of just doing the injectables, considering surgery. So that should all make sense. That's part of clinical decision making. So putting it all together involves, constantly assessing the acuity level at different stages and then acting based on if it's low or high. So the higher acuity situation needs more evaluation and more treatment during the management phase. So let's do a couple of cases that maybe illustrate this point of some sports injuries. Here's a 21-year-old who fell directly onto his knee playing basketball 5 days ago. They were able to finish the game, but the knee got pretty sore that evening. They didn't have a ton of swelling, maybe some bruising. They're able to walk, but stairs hurt, kind of tender anteriorly. The knees try to do forceful extension. It hurts. It's not necessarily weak. You can't break their knee extension strength. So, you could tell that the loss of function, the red flag findings in this scenario during the evaluation phase is kind of low. That just looks like not like a deformed knee. It's just discolored. It's bruised. It doesn't look like it's got a huge intra-articular fusion. So the acuity level in this situation, at least initially, pretty low. So we can feel comfortable not turning the world upside down, trying to find answers or trying to administer treatment. Kind of looks like a knee contusion, like just by clinical assessment. So we would just do the simple things, right? Similar situation, 15-year-old fell on the knee playing basketball 10 days ago. They tried to keep playing that day, but they couldn't finish. The knee hurt too much. And instead of no real swelling, they had some. And instead of being able to walk and only have pain with stairs, they had to limp when they walked. And they're both tender anteriorly, and they had painful range of motion, and the knee extension strength seemed reduced. Still looks the same. What's the acuity level now? It's a very similar clinical vignette, but I would say that it's not a low acuity level. It's now a more medium level acuity level because there are a few more red flags on the physical exam and a little bit more effect on the function or more loss of function in this situation than the previous situation. So that a medium acuity level on evaluation generally means we need to do more exploration. So in this case, we got x-rays and there was no fracture. So we just called it's still knee contusion, same treatment, but because the acuity level is a little bit higher, then the management portion of it requires us doing a little bit more, maybe recommendations of more time off, maybe using a brace, maybe doing a stronger prescription strength anti-inflammatory rather than over the counter. So again, these are just examples of it's the same contusion, a little bit different, same diagnosis, a little bit different presentation that changes the acuity level, and then our evaluation and management of it changes accordingly. Okay, how about a third example? They fell on their knee playing basketball 10 days ago. They tried to keep playing that day, hurt too much. They had some swelling, they're limping, they're tender. So this is all exactly the same as case two. Looks the same, and because the acuity level is medium, we should do more. We should get some x-rays. And lo and behold, this person has a vertically non-displaced patella fracture. And so that is a imaging red flag finding that warrants an entirely different set of treatments as opposed to the knee contusion. So this is just illustrating how some of the red flags that we find on history and exam are driving our decisions of how much to evaluate or how much to treat. And then there are some imaging red flag findings that then escalate the situation even to a different level of what we have to do from a treatment standpoint. Okay. Patella, same thing. 31-year-old fell on his knee playing basketball earlier today. Can't walk, crazy swelling, can't straighten the leg. Knee looks is tender, it looks deformed. What's the acuity level here? Pretty high. They can't walk. That's like a pretty big loss of function. That's a pretty big red flag. So this means we need to do more, get x-rays, send to the ED, crutches, wheelchair immobilization, and ultimately we see a displaced patella fracture and a different treatment compared to the non-displaced patella fracture because then this one needs the surgery to make that right. So again, 4 cases illustrating varying levels of acuity with essentially the same clinical vignette with little tweaks here that then lead to quite different evaluations and ultimately treatment just because of how that acuity level assessment was different between one vignette and the other. Okay, let's use another really common knee sports injury situation here. 35-year-old playing rec soccer, loaded her knee while flexing and turning, felt a pop. Couldn't walk, can't extend, a lot of swelling, joint line tenderness, hard to do ligament exam because of swelling. This evaluation shows high acuity. We need to do more and we need to do it more, expeditiously. So we get x-rays, there's no fracture. In this situation, because they can't walk, we probably should get an MRI because it's a pretty high acuity assessment. And then, in this situation, we see a displaced bucket handle meniscus tear. And again, crutches, surgery, find something like this where there's a tear through the posterior horn of that lateral meniscus. And here we do some stitches and get that right. Okay. Next case, example 6, 35-year-old playing rec soccer, loaded her knee while flexing, turning 2 weeks ago. Felt a pop, can walk, but can't run because of the pain. Can extend and flex, but it hurts. Some swelling, some joint line tenderness, seems stable on ligament testing. So this is a different situation than the very high acuity level situation, which was the previous case. And so it's more than low. We should do something. Let's get some x-rays. They're normal. Now what? So many people will get an MRI. This is where there's maybe some room for clinical discretion, someone who doesn't have a hard block of motion, someone who's able to walk, someone who had an injury 2 weeks ago. Some people will get an MRI to get a firm diagnosis in hand. Some people, I'm the included in the group that maybe we'll just start treating. And the reason why is because we've done the work to rule out the dangerous things like fractures, dislocations, or badly displaced things, because those are commonly associated with a hard block of motion and a different presenting set of red flag findings on physical exam. So even if we suspect a meniscus tear, uh, um, because the acuity level is medium, not crazy high, like in the case before, we can treat. I think it'd be safe to do, plus minus surgery consult. Some of this is dependent on your comfort level and your practice pattern and setup, but it's a medium acuity level assessment. Okay, we could probably do some PT, do some medicines, topicals, see how it goes. Okay. Let's say it's that same patient now, but now it's 3 months later, and you've tried all of these things. You've done all of these things. They can jog and run now, but it still hurts. And the knee swells, but it 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 it's when they try to go harder with soccer. They have their motion now without real pain. The swelling's a little bit better. The joint line tenderness is better. Seems stable. So again, it's that same scenario as case example 6, but now 3 months later uh, after trying some stuff. So we need to do more because the acuity level is higher than medium because we've tried a bunch of things and they're still having some symptoms or problems. Now, again, this is where I didn't put this in the vignette, where some patients in this scenario say, yeah, let's just give it more time. I'm not sweating this that much. I'm okay. And then there's some people who are losing their minds. And that's where that patient frustration or how fed up the patient is can really then add to whether or not the acuity level has risen a lot more with your treatments or not. So let's say this patient is frustrated. It's been 3 months, kind of 3 months waiting for an injury to settle down is a pretty fair amount of time. So now we got to start getting advanced imaging, start thinking about potential surgery consult. And here we see the non-displaced meniscus tear, which makes sense because they got their motion back and they didn't have a crazy high acuity level to begin with. And just a small little tear of the meniscus that gets cleaned up and looks all clean after we do that surgery. So again, three meniscus injury cases, all the same diagnosis and but presenting with different levels of acuity, all the same mechanism, the same in soccer injury, plant and feel a pop, but warranting quite different management approaches because of the different acuity level. And again, that evolves over time. You know, it takes time to administer treatments, and it takes time to for a patient to build a to demonstrate a response to that treatment, whether it's good or stagnant. I wanted to add a few miscellaneous sports knee trauma pearls because I wasn't going through all of the individual uh, knee traumatic sports injuries, diagnosis by diagnosis. You know, I think everybody knows I want to make a point of this that an acute sports injury with immediate swelling, it's usually hemarthrosis. And so, very high on the differential diagnosis should be a cruciate ligament tear, most common is ACL, an intra-articular fracture or a displaced piece of cartilage or an extensor mechanism injury. I find that the trainees, the residents that come through my clinic often miss number four, that a hemarthrosis can be can be associated with an extensor mechanism injury like a patella subluxation. The initial acuity assessment on evaluation, at least in my experience, it seems to nicely correlate with the amount of time that they're likely to miss. So in our world, in high level sports, we're often being asked to predict the future. Doc, how long is this blank knee sports injury going to keep the player out, my son out, me out? And I find that funny because we are cannot tell the future. But if you wanted some help to try to predict or tell the future, I would actually use your acuity assessment as a proxy of how long it might take for someone to get back. So low acuity problems, often the athletes are missing minimal time, or they can go as tolerated once the pain allows, or once they have no more swelling and no more, and they have full motion, full strength. Medium acuity problems, so problems that by your acuity assessment is medium level, something more than low, they're going to miss something. You know, maybe it's as little as a week, maybe it's a few months, but they're going to miss something if they're presenting as a medium acuity problem on your assessment when you evaluate them. The high acuity problems, they can't walk, they can't move their knee, they've got crazy swelling, there's ligament laxity. These are like high acuity problems because of the red flag findings or the loss of function. They're missing 3 months or more, you know, depending on the problem and if they need surgery or not. I would say the exception to that is soccer. Soccer athletes fall and they look like they're going to die, but they'll get right back up. So I actually don't try to make any predictions on soccer injuries because the flopping involved in soccer is like off the charts. And so that's maybe the one exception of acuity assessment that you can't really rely on how long they're going to be out for. Okay, some specific injuries, you know, like fractures around the knee as a sports injury. We think of these articular fractures of the tibia plateau, the proximal fibula, patella, distal femur, or spine avulsion fractures. I kind of loop dislocations and subluxations into that group as well. I think of these bony injuries as 3 month problems. So when you land on a fracture as a diagnosis, they're usually feeling pretty messed up. The acuity level is usually pretty high. Can't walk on it, for example, can't bend or move it, crazy swollen. And you just know that lines up with a 3 month or more recovery. Ligament tears are variable. I think of non-surgical ligament tears being 2-month problems, 6-week problems, 2-month problems, maybe up to 3-month problems. And then when ligament tears need surgery, it's 6 months or more. You'll see a common theme going on with this. Tendon injuries also can vary. Minor strains usually present as low acuity, still able to walk, still able to fire, still able to move their knee. Moderate strains, something less than that. They get some weakness. They have a little bit harder time, like maybe with running, maybe walking is okay. So these are medium level acuity situations, and these often correspond with moderate strains taking 3 to 4 weeks, maybe up to 6, maybe a couple months. And then these severe ones, where they can't walk. It's the knee looks blown up when they strain their hamstring, their distal hamstring, or partially tear or badly pull their distal quadriceps. These ones can often take 6 weeks or more. And then surgical injuries like full thickness tears of the patella tendon, quadriceps tendon requiring surgery 6 months or more. Again, common theme here. And just like the tendon and ligament injuries, cartilage injuries can vary in terms of when they can get back, but they seem to correlate with the acuity level, at least on initial evaluation. So the non-displaced tears can present as mild or moderate acuity, and the displaced tears more often present as moderate to severe acuity situations on your initial evaluation. And that correlation is kind of sticks with it with surgeries. So the cleanup surgery of a non-displaced or a small meniscus tear is I think of as a 6-week recovery, and big repairs being 3 or months or more, with the displaced tears. Okay, so in summary, there are evaluation principles and management philosophies that can be broadly applied to the knee sports trauma scenario and others, to be honest, that help guide decision making and counseling as team physicians or musculoskeletal experts like we all are. Using the acuity assessment during evaluation and the management phases can help drive treatment decisions and kind of keep you in the right space, whether it's what you're about to do for this athlete in front of you, or when someone's asking you what's going to happen or how long is it going to take, for this athlete to get back, or what are they going to end up needing, even when you have yet to 100% confirm the diagnosis or what traumatic they got injured. So again, that acuity assessment it's a very common sense thing that I think most people intuitively do, but maybe this talk is just, outlining it in a form that can be thought about more intentionally. So that's all I have. Again, I got amazing partners at the University of Washington in our Department of Orthopedics, and we're growing, as we speak. And again, I appreciate the time, Doctor, everyone involved in sticking around with this and catching this on the video later. If there's any info, this is my contact info. Any questions, comments, or just need help with anything, you're in the Seattle area or even across the country, I'm always happy to field any emails or calls. And that's it. That's all I have.
Chris, this is great. Thank you so much for giving it. I love this idea of like kind of framing the acuity and how it drives different parts of the management. It's a really cool way to kind of um, I don't know, sort of collate each part of the evaluation and management strategy and how it's sort of a slider and how it kind of goes up and down depending. And it's not just about the mechanism, it's about patient preferences and like all these other things. Along those lines, just a couple of questions. The first one is, you mentioned like obviously we talk about bracing and immobilization. Certainly in the emergency department, we are notorious for over immobilizing joints. When you're looking at that varying like low, moderate, or low, medium, and then high acuity stuff, how do you frame bracing slash immobilization in each of those buckets? And I realize every case is unique, but in general, like a general approach to each category, how aggressive should we be about protecting the knee in those situations?
Yeah, I think that it's safe to say that if you are looking at your determination of a low acuity situation, there's not a lot of red flags. It's not deformed. They can move it. They can bear weight. You obviously don't need to brace or mobilize that. And so when you have and then I think it's very intuitive for everyone when it's a hike, they can't walk, they can't put weight on it, they can't move it, that you have to immobilize, splint, or brace that. So now, so you're talking about these middle situations where you assess it to be a medium or a medium level acuity where can't they're kind of limping, they're kind of not. So to me, it's aggregate. I think that if they're having a hard time putting weight on their knee, they need crutches. Okay. If they're limping real badly, they should use crutches. I mean, that's the instructions that I give my post-op patients with after knee scopes, for example, where that's weight bearing is tolerated. But I tell them if you're limping, if it's swollen, if it hurts a bunch, then use crutches. And then when those things settle down, then you don't have to use the crutches anymore. So that's just a really simple metric that I use or that anyone could use in the ED or urgent care setting, for example. Bracing to me is plus minus. Like if you suspect a ligamentous injury, bracing is or a straight leg immobilizer is a great thing to do. You suspect a patella subluxation, lock them down in something so that they don't mess with it, so they don't have the immediate recurrence, right? That's what you want to avoid, right? So the bracing to me is to if you on your physical exam get a sense that there's some laxative valgus stress, for example, I would put them in brace. I wouldn't hesitate. And then the nice thing that about it is, you're just trying to bridge the gap until the next eval, right? And sometimes the next eval happens in the office the next day. Sometimes it happens in the training room, like in a few hours. Sometimes you don't know when it's going to happen. You're worried it might not be for weeks because of their social situation. And I think that if you know you have closer, tighter follow-up available, you can be um, you have more flexibility. You could like over immobilize and be okay because you know they're going to get out of it in a day or two. Or you could under mobilize it and you could be okay because in a day or two someone could like assess them again and then put them in something that's more appropriate. When you are worried that they're going to be farther out for the next checkpoint, then you have to really kind of put everything into account, their social situation. Do they seem like they're going to listen? Do they seem like they're going to like they have common sense, that they know like the callback precautions, or like, do we think that they're going to be an idiot and just try to like put weight on it right away when they shouldn't? So I think that kind of goes into it in those medium acuity level situations.
Oh, that's great. I appreciate that. There was one other question, and it has to do with that higher acuity category where you're getting plain films and, assuming that they're negative, what do you MRI all of those people? Is there like certain, things that you're looking for when they kind of naturally fall into that higher acuity category that helps you decide whether or not to pull the trigger on an MRI?
Yeah, I think MRI is um I think we over order MRIs when we're trying to figure out a diagnosis. So maybe that would be the differentiation point that I would maybe try to make or argue for is that I get MRIs because there's so many red flags in the situation, or the acuity level is so high that it warrants that next level evaluation, or like to try to really more firmly land on a diagnosis because they're so messed up, there's so many red flags, the acuity level so high. Like that's to me the rationale for getting an MRI. When you I think what we often do is getting an MRI because we don't yet have a diagnosis, like a firm diagnosis in hand, right? X-rays are negative, but something doesn't seem right. So we need to figure out what that is. And advanced imaging is obviously the easiest way to do that, although costly and kind of cumbersome and all that. So to me, if the question is like why some get an MRI, some don't, I would say that explains at least some of that ordering behavior. And then the other is time. Like I will often like when I don't like my practice now, I often see people after they've been worked up or have MRIs, but I sometimes see patients who are just, a day after an accident and just need to be seen and I have an open spot. And I will often try to do the things that I think will help the situation. Like they're limping, give them crutches. They have pain, give them medicines. They have swelling, tell them to ice and elevate and compression wrap, and then offer a short turnaround. And assuming that there's no other red flag findings, like there's nothing gross instability on Lockman testing, an incarcerated knee that can't extend. As long as those things aren't there, then I will often just treat, see what happens, and then see how it unfolds. Because remember, you should be doing this acuity assessment every time you see someone, and it changes over time. So let's say you see them a week later and the swelling is down, and they could put weight on it, and they feel a lot better. Then you know that you would be probably okay without getting advanced imaging. And then vice versa, like the knee's still crazy swollen, they're still in a ton of pain. They tried to put weight on it, it doesn't feel. Now it's not swollen as much, and now you could get a better exam, of the ligaments. So you get that information, then it could change. It changes the sliding scale on it, right? I think what the wrong thing to do is to get an MRI because you don't know what's happening, because you actually don't need to have it. The beauty about this philosophy, management philosophy and evaluation principle is you don't actually have to have a hard diagnosis in hand to start doing the right thing for them, in terms of treatment and management. That's why I think this is a nice way to anchor the clinical decision making around.
That's a great perspective. I love it. I love the idea of maybe not throwing everybody in the magnet right away, that maybe doing a little bit of thinking and giving some people a little bit of time and that kind of stuff. So that's awesome. Well, thank you so much for your time. I think that was the end of our questions. Thanks to everybody that joins now, that had joined for now, and those that will be joining and checking it out later on. Everybody have a great summer, and we'll see you at the next lecture in August. Thanks, Dr. Kwan.
Take care. Thank you.